Hi, my name is Laura, and welcome to my audio version of the Family Medicine Cardiovascular EOR Study Guide. The rest of the family medicine topics can be found on my channel, but I'll link them below as well. This review is going to follow the PAEA cardiovascular portion of the Family Medicine End of Rotation exam topic list, and I'll timestamp all the topics below in case you'd like to skip around. If you had a chance to listen to the Women's Health Study Guides, then you know the background to these videos. My goal is a short and sweet, but comprehensive review that prepares you for each EOR exam. So let's start family medicine off with the cardiovascular topics. First up is hypertension, and we'll lay the foundation here with the AHA guidelines for blood pressure. Normal blood pressure is anything less than 120/80, meaning a systolic is less than 120 and diastolic is less than 80. Elevated blood pressure is a systolic less than 130 and a diastolic less than 80. Stage 1 hypertension is a systolic of 130 to 139 or a diastolic of 80 to 89, and stage 2 hypertension is a systolic of 140 or greater or a diastolic of 90 or greater. In order for a diagnosis to be made, elevated blood pressure must be present in 2 different readings at 2 separate visits. Etiologies are broadly grouped into primary or central hypertension and secondary hypertension. About 95% of hypertension is primary, meaning it's idiopathic. The onset is between 25 to 55 years old, and often there's a family history. Secondary hypertension, on the other hand, has an identifiable underlying cause and is sometimes correctable. The most common cause is renovascular hypertension, also called renal artery stenosis, in which there's a narrowing of the arteries that perfuse the kidneys. What happens is that this stenosis leads to poor perfusion in one or both of the kidneys, which makes the kidneys think that the problem is hypotension, so they increase RAS activation, the renin-angiotensin-aldosterone system. Renovascular hypertension should be suspected in hypertension onset younger than 20 years or older than 50, in severe hypertension, or if it's resistant to 3 or more drugs. The underlying cause is often atherosclerosis in the elderly or fibromuscular dysplasia in younger patients. Other causes of secondary hypertension include hyperaldosteronism, pheochromocytoma, Cushing's syndrome, coarctation of the aorta, sleep apnea, ETOH, oral contraceptives, and COX-2 inhibitors. There are many complications of high blood pressure, so I'm just going to list a few of them here. Coronary artery disease, heart failure, heart attack or MI, aortic dissection, stroke, ruptured aneurysms, renal disease, retinal hemorrhage, blindness, and more. Of note, papilledema on a fundoscopic exam is more prognostic than an isolated blood pressure measurement, and it's indicative of an advanced stage of malignant hypertension. So let's move on to treatment, which is important to decrease the risk of all the complications we just listed. Initial recommendations are always lifestyle modifications, like weight loss, DASH diet, and exercise, even if you're also prescribing medications. Medications typically include diuretics and vasodilators, so let's go over each type in depth, and then we'll review which med to prescribe and when. The diuretics include thiazides, loop diuretics, and potassium-sparing diuretics, and these work by decreasing blood volume and therefore pressure by excreting more sodium in water. Thiazides, like hydrochlorothiazide and chlorthalidone, are often the first-line treatment of choice for initial therapy in uncomplicated hypertension. They inhibit the reabsorption of sodium chloride in the distal convoluted tubule, meaning more sodium chloride, and thus water, is excreted by the kidney. I remember this mechanism because water follows salt. So thiazides decrease sodium, chloride, potassium, hydrogen, and magnesium, and they increase uric acid, calcium, and glucose. Therefore, side effects can include hyponatremia, hypokalemia, hypercalcemia, hyperuricemia, and hyperglycemia. So use caution in patients with gout and diabetes. Loop diuretics like furosemide, bumetanide, and torsemide are the strongest class of diuretic and are primarily used for CHF and edema rather than hypertension. Loop diuretics work by inhibiting the sodium-potassium 2-chloride cotransporter, primarily in the ascending loop of Henle, resulting in excretion of sodium, chloride, potassium, and water. Loop diuretics decrease sodium, chloride, potassium and calcium, and they increase uric acid and glucose. Therefore, side effects can include hypokalemia, hyponatremia, hypocalcemia, and hypochloremic metabolic alkalosis, as well as hyperuricemia, hyperglycemia, and ototoxicity. They're also contraindicated in those with a sulfa allergy. Potassium-sparing diuretics include the sodium channel blockers and the aldosterone antagonists, and they primarily work in the collecting duct. Sodium channel blockers like amiloride or triamterene inhibit sodium channels. Aldosterone antagonists like spironolactone or eplerenone inhibit aldosterone-mediated reabsorption of sodium and excretion of potassium. These are weak diuretics that are most useful in combination with other meds in order to minimize potassium loss. Side effects can include hyperkalemia, as well as gynecomastia with spironolactone, and they are contraindicated in renal failure. So those were all of the classes of diuretics. In general, they are excreting sodium, and therefore water, to decrease blood volume and thus blood pressure. The vasodilator medications can be broken down into ACE inhibitors, angiotensin II receptor blockers, or ARBs, calcium channel blockers, beta blockers, and alpha-1 blockers. So let's start with ACE inhibitors. This drug class has the ending pril, like enalapril, lisinopril, captopril. They work by inhibiting the activity of angiotensin-converting enzyme, or ACE, a component of the renin-angiotensin system. This system is activated by reduced renal blood flow, which is perceived by the kidneys as hypotension. So the kidneys think there's not enough blood, and they start working to increase blood pressure, which is great if your arm was bitten off by a bear and you're bleeding out, but not so great if the cause is renal stenosis. Activation of the RAS system causes the kidneys to secrete renin into the bloodstream, which converts angiotensinogen to angiotensin 1. And then angiotensin-converting enzyme, or ACE, converts angiotensin 1 into angiotensin 2. And angiotensin 2 is a potent vasoconstrictor that increases blood pressure. Angiotensin 2 also stimulates aldosterone secretion, which causes the kidneys to reabsorb sodium and thus water, further increasing blood pressure. ACE inhibitors disrupt this pathway by inhibiting angiotensin-converting enzyme, preventing the production of angiotensin 2. They are also cardioprotective and renoprotective. ACE inhibitors are often prescribed for hypertension, especially in patients with diabetes, nephropathy, CHF, or an MI history, and they have a synergistic effect when used with thiazides. Side effects of ACE inhibitors can include hyperkalemia, cough, and angioedema, and they're contraindicated in pregnancy due to teratogenic effects. The next medication is angiotensin II receptor blockers, commonly called ARBs, which have the suffix artan, like losartan or valsartan. ARBs block the effects of angiotensin II rather than its production. They're often used in patients who can't tolerate ACE inhibitors, so they have similar indications. Side effects include hyperkalemia, and they are also contraindicated in pregnancy. Calcium channel blockers can be divided into dihydropyridines and non-dihydropyridines. So dihydropyridines end in dipine, like amlodipine or nifedipine, and these are potent vasodilators often used for hypertension treatment. Non-dihydropyridines include verapamil and diltiazem, and these are potent vasodilators that also affect cardiac contractility and conduction. So these can be used for hypertension with AFib. The main side effect to know for calcium channel blockers is peripheral edema in the legs, and also verapamil can cause constipation. Beta blockers have the suffix olol, and they work by inhibiting beta adrenergic receptors. So there are beta 1 and beta 2 receptors. Beta 1 receptors are located primarily in the heart, kidneys, and fat cells, and regulate force and rate of cardiac contraction, as well as renin release in the kidneys. Beta 2 receptors are located primarily in the lungs and smooth muscles, and they mediate bronchodilation and smooth muscle relaxation. Some beta blockers are cardioselective, meaning that they block only beta 1 receptors, decreasing heart rate and contractility, which then decreases blood pressure. The cardioselective beta blockers include atenolol, metoprolol, and esmolol. Other beta blockers are non-selective and block both beta 1 and 2 receptors. These are contraindicated in asthma because blocking beta 2 receptors can lead to bronchoconstriction. Non-selective beta blockers include propranolol, nadolol, and timolol. And then some are non-selective and block alpha-1 receptors as well, like carvedilol and labetalol. Alpha-1 receptors are located primarily in smooth muscle and most blood vessels, and blocking them leads to vasodilation. In general, beta blockers have a wide variety of uses, including hypertension, but they are not used as first-line monotherapy for hypertension. Side effects include depression, impotence, and they can mask sympathetic symptoms of hypoglycemia, so use with caution in diabetic patients. Alpha-1 blockers are next, and these have the ending zosin, like prazosin, terazosin, and doxazosin. These can be used for hypertension but are also not first line, and are more commonly prescribed for benign prostatic hypertrophy, or BPH. As mentioned before, they cause vessel dilation. Now that we've covered most of the hypertension meds, let's go over how to pick one. In uncomplicated hypertension in non-African American patients, the initial medication can be from any of the following drug classes: thiazide diuretics, ACE inhibitors, ARBs, or calcium channel blockers. African Americans and elderly patients typically respond better to thiazide diuretics or long-acting calcium channel blockers. And younger patients, less than 50 years old, respond better to ACE inhibitors, ARBs, and beta blockers. But remember, beta blockers are not used as initial monotherapy. Choosing an initial blood pressure medication largely depends on treating other comorbid conditions, because some patients have additional disease processes that make certain hypertension drugs a better first-line choice over others. ACE inhibitors are first-line in all patients who have heart failure, systolic dysfunction, diabetes, chronic kidney disease, and history of a STEMI or NSTEMI. You can remember this because ACE inhibitors, and ARBs too, have cardioprotective and renoprotective effects. That being said, ARBs have the same indications as ACE inhibitors, so if the patient cannot tolerate the side effects of an ACE, often because of a cough, then try an ARB. Thiazide diuretics are appropriate first-line monotherapy in patients with hypertension and osteoporosis. The advantage that thiazides have over ACEs, ARBs, and calcium channel blockers is that they stimulate distal tubular reabsorption of calcium, so less is excreted in the urine. This has a beneficial effect on bone mineral density with decreased rates of hip and pelvic fractures. Calcium channel blockers don't have any absolute indications for use as first-line monotherapy, but should be considered in certain patients who also need rate control of AFib or angina control in coronary artery disease. Calcium channel blockers might also be ideal in patients with hypertension and gout, since diuretics, ACEs, and most ARBs are associated with an increased risk of gout. So if there's little or no improvement on one medication, some sources recommend increasing the dose or switching to another class of drug as monotherapy, instead of adding a second medication. If there is improvement on one drug but the blood pressure is still too high, increasing the dose of that drug is appropriate. And if blood pressure is still not controlled after this, then consider adding another medication from another drug class. The last part of this section is hypertensive urgency and emergency. Hypertensive urgency is an increase in blood pressure greater than 180/120 without any signs of end organ damage. The drug of choice to treat hypertensive urgency is clonidine, an alpha-2 agonist. Hypertensive emergency is an increase in blood pressure greater than 180/120 with impending or progressing end organ damage. The drug of choice to treat hypertensive emergency is nitroprusside. And I'm going to leave it at that at the basics since we're in family med now, but we'll go more in depth in the internal medicine videos. The next topic is hyperlipidemia, which includes hypercholesterolemia and hypertriglyceridemia, so we'll go over all of that here. Let's start with the screening guidelines. Cholesterol screening in high-risk individuals should begin around 20 to 25 years in males and 30 to 35 years in females. In lower risk patients, screening should begin at age 35 for males and 45 for females. According to the AHA, it's reasonable to reassess every 5 years in patients that do not have cardiovascular disease. Target values for total cholesterol are less than 200. Target values for LDL, the bad cholesterol, are less than 100. High total cholesterol or high LDL is called hypercholesterolemia. Target values for HDL, the good cholesterol, are greater than 60, since this type of cholesterol is protective. Target values for triglycerides are less than 150. High triglycerides is called hypertriglyceridemia, and hyperlipidemia is the umbrella term for all of these. Most patients with hyperlipidemia are asymptomatic. Some may develop xanthomas, which are localized lipid deposits in the skin, tendons, and subcutaneous tissue. Significant hypertriglyceridemia may also cause pancreatitis. First-line treatment for all types of hyperlipidemia is lifestyle modification, meaning diet and exercise. First-line pharmacotherapy is typically a statin. There are 4 rules that guide the initiation of statin therapy. Number 1, begin statin therapy in any patient with clinical atherosclerotic cardiovascular disease. Number 2, begin statin therapy in any patient with LDL cholesterol levels of 190 or greater. Number 3, begin statin therapy in patients aged 40 to 75 with an LDL level greater than 70 and diabetes. Number 4, begin statin therapy in patients aged 40 to 75 with an LDL level greater than 70 and an estimated 10-year ASCVD risk of 7.5% or greater. This risk can be assessed using an online ASCVD risk calculator. Now let's go through the medications. Lipid-lowering drugs include statins, fibrates, bile acid sequestrants, niacin, ezetimibe, and omega-3 fatty acids. Statins are by far the most common, and conveniently they all end in the suffix statin, like atorvastatin or simvastatin. They come in high, moderate, and low intensity, depending on the specific drug and dose, and are the best drug to reduce LDL, the bad cholesterol. Statins reduce cholesterol production by inhibiting the rate-limiting step, leading to a decrease in LDL, with a modest triglyceride-lowering effect, typically by 10 to 15%. So statins are good for treating high LDL, but they should not be used alone in patients with severe hypertriglyceridemia. These patients need an additional med. Statins are also contraindicated in pregnancy and lactation, as well as liver disease, so monitor liver function tests. The main side effect to know for statins are myalgias and cramps, which are called statin-associated muscle symptoms, or SAMs, and can sometimes include elevated creatinine kinase levels. Ezetimibe, or Zetia, is a drug that is often used alongside statins to further decrease LDL. It's never used as monotherapy, though. It inhibits intestinal absorption of cholesterol to decrease LDL. It's well tolerated, few side effects, but monitor liver function tests, or LFTs. Fibrates are the best drug to decrease triglycerides. In isolated hypertriglyceridemia, fibrates are first line. These include gemfibrozil and fenofibrate, and they inhibit peripheral lipolysis and reduce hepatic triglyceride production. This leads to reduction in triglycerides, as well as an increase in HDL, the good cholesterol. Fibrates are contraindicated in hepatobiliary disease and severe renal disease. Side effects include increased LFTs, myositis, and myalgias, especially with concurrent statin use, and increased risk of gallstones. Niacin, also known as vitamin B3, is the best drug to increase HDL and the second best drug to decrease triglycerides. It works by reducing HDL clearance and reducing hepatic production of LDL and its precursor VLDL. The predominant side effect of niacin is flushing, which can be treated with aspirin prior to niacin. Other side effects include headache, pruritus, hyperglycemia, and hyperuricemia, so use caution in diabetics and gout patients. Bile acid sequestrants, like cholestyramine, are most useful in combination with a statin or niacin to aggressively lower LDL levels. They bind bile acids in the intestine, which prevents enterohepatic reabsorption. The liver then has to make new bile acids, so it increases its LDL receptors, removing LDL from the blood. Bile acid sequestrants are not systemically absorbed, so they are the only cholesterol med safe in pregnancy, and are also used for pruritus associated with biliary obstruction. LFTs need to be monitored. Bile acid sequestrants also cause an increase in triglycerides and should not be used in patients with hypertriglyceridemia. All right, that wraps up hyperlipidemia, so let's move on to coronary artery disease. Coronary artery disease occurs when there is reduced coronary blood supply but increased demand. The most common cause of coronary artery disease is atherosclerosis, which occludes the coronary vessels. Other causes include coronary artery vasospasm, aortic stenosis or regurgitation, pulmonary hypertension, severe systemic hypertension, and hypertrophic cardiomyopathy. Risk factors for coronary artery disease include diabetes, smoking, hyperlipidemia, hypertension, male gender, increased age, family history, and obesity. So as we said, atherosclerosis is the most common cause of coronary artery disease. Lipids get deposited in vessels and become fatty streaks and then fibrous plaques, resulting in calcification and narrowing of the coronary artery lumen. This reduces cardiac blood flow during times of increased demand, like exercise or emotional stress, and can lead to myocardial ischemia. Patients usually become symptomatic when there is an occlusion of 70% or more. Symptoms of coronary artery disease range from asymptomatic to chest discomfort and shortness of breath. Chest pain from coronary artery disease is called angina and can be classified as either stable or unstable. Stable angina is predictable and presents with a consistent amount of exertion. Relief is achieved with rest or nitroglycerin. Unstable angina is less predictable and can present during rest. There's limited improvement with nitro, and unstable angina is often recurrent. Unstable angina can be indicative of a ruptured plaque with clot formation in the vessel. Definitive diagnosis of coronary artery disease is done by cardiac catheterization, where they enter the coronary vessel with a small wire and shoot contrast dye into them, called angiography. This allows the provider to visualize any blockages in the coronary arteries. We'll go over treatment in the next section on chest pain since these topics are going to overlap quite a bit. Angina pectoris is substernal chest pain that is usually brought on by exertion due to decreased coronary blood flow and increased demand. It is traditionally described as poorly localized, non-pleuritic, exertional, sometimes with radiation to the arm, teeth, jaw, back, epigastrium, or shoulder. Levine sign, a clenched fist over the chest, is often present as well. And the chest pain is often relieved by rest or nitro. Other associated symptoms include dyspnea, nausea, and diaphoresis. Some patient populations, like women and diabetics, do not have the classic chest pain presentation but will complain of dyspnea, epigastric, or shoulder pain. Angina is primarily a history diagnosis, so getting an accurate clinical history is important. Workup begins with an EKG. A resting EKG is normal in about half of patients with stable angina. Abnormal EKGs often show ST depression, T-wave inversion, poor R-wave progression, or left ventricular hypertrophy. It's important to note here that if the patient is actively having chest pain and a cardiac etiology is suspected, cardiac biomarkers like troponin need to be assessed to rule out an actual, acute myocardial infarction. The next step in workup is stress testing, which can include a stress EKG, stress nuclear myocardial perfusion scan, a stress echocardiogram, or cardiac MRI. A stress EKG can be performed on a treadmill or pharmacologically and involves constant monitoring with EKG tracing and blood pressure cuff. A positive stress test will show ST depression, hypo or hypertension, arrhythmias, or clinical symptoms. Stress nuclear myocardial perfusion imaging is done for patients with baseline EKG abnormalities. It can be done with exercise or pharmacologically and is used to localize regions of ischemia in the heart. A stress echo, which can also be done with exercise or pharmacology, gives more structural information, can locate ischemia, assess wall motion abnormalities, assess left ventricular function, and valvular disease. A stress echo is often paired with a stress EKG for further information. Finally, a cardiac MRI can be used as an alternative to a stress test. This imaging is performed with a dobutamine infusion and can assess cardiac perfusion and wall motion abnormalities. Okay, a quick note here. In the first 3 aforementioned stress tests, the stress EKG, stress nuclear myocardial perfusion scan, and the stress echo, stress can be induced by exercise or pharmacology. The drug options are typically adenosine or dipyridamole, which are coronary vasodilators. These are contraindicated in asthma, though, due to risk of bronchospasm, so asthmatics receive dobutamine, a positive inotrope and chronotrope that increases myocardial oxygen demand. Alternatively, if the patient is able, they can be put on a treadmill for exercise-induced stress. The last part of the stable angina workup is coronary angiography, commonly referred to as cardiac catheterization or the cath lab. This is the gold standard for definitive diagnosis. It defines the location and extent of coronary artery disease. Coronary angiography is indicated in patients with symptoms consistent with coronary artery disease in order to confirm or exclude the diagnosis. It's indicated in patients with symptoms of coronary artery disease in whom stress testing was negative. And it's indicated in patients who may possibly need revascularization of coronary arteries. Revascularization of coronary arteries can be done by percutaneous transluminal coronary angioplasty or by coronary artery bypass graft, commonly called a CABG, CABG. Angioplasty is a minimally invasive procedure done in the cath lab, so no open heart surgery or anything like that opens up blocked coronary arteries to improve blood flow to the myocardium. By the way, this procedure is also called percutaneous coronary intervention or PCI. So it's indicated when one or two vessels are involved, but that can't include the left main coronary artery since it branches into too many important things, and ventricular function has to be normal or near normal. Stents are often placed during this procedure to help prevent restenosis, which was especially common before stents were used. Stents reduce restenosis rates, but restenosis is still a concern, so patients are generally prescribed a combination of aspirin and clopidogrel after angioplasty, or PCI, to prevent stent thrombosis. In patients who have coronary artery disease of 3 or more vessels, or of the left main coronary artery, or who have decreased left ventricular ejection fraction, then a coronary artery bypass graft, or CABG, is indicated. This is an open heart surgery in which a healthy blood vessel from elsewhere in the body is grafted to the blocked coronary artery in order for the blood to have an alternate route around the blockage to perfuse the myocardium. So let's back up just a bit to the pharmacological management of angina, especially in the family med outpatient setting. The classic outpatient regimen consists of a daily aspirin, beta blocker, statin, and nitroglycerin as needed for chest pain. The aspirin reduces the risk of thrombosis by preventing platelet aggregation. The statin controls cholesterol, which contributes to atherosclerosis. The beta blocker is important because it increases diastolic timing. Coronary arteries fill during diastole, so when diastole is prolonged, the coronary arteries get more blood supply and the myocardium is better perfused. Beta blockers are also negative chronotropes and inotropes, meaning they decrease heart rate and force of contraction respectively, which reduces the myocardial oxygen requirements. For similar reasons, calcium channel blockers are an alternative in patients who can't take beta blockers. Nitroglycerin is also used as needed when the patient experiences symptoms. Nitro is a vasodilator. It increases perfusion to the myocardium by dilating the coronary arteries, and it decreases the work that the heart has to do by reducing preload and afterload through venodilation. Because of this, nitro has well-known effects of headache and hypotension. It's contraindicated in patients with a systolic blood pressure below 90, in patients with a right ventricular MI, because these patients are preload dependent, and it's contraindicated in patients who have taken a phosphodiesterase 5 inhibitor, like Viagra or Cialis, in the last 48 hours. Okay, so what we've gone over so far is more or less the outpatient workup for stable angina due to coronary artery disease. So let's go through other differentials for chest pain now. Acute myocardial infarction should be at the top of the differential list due to its acuity. A STEMI, or ST elevation myocardial infarction, is a heart attack that presents with ST elevations on a 12-lead EKG and positive cardiac biomarkers, namely troponin. An NSTEMI, or non-ST elevation myocardial infarction, is a heart attack with positive troponins but no ST elevation on 12-lead. Other EKG changes might be present though, like ST depression or T-wave inversion. Another differential should be unstable angina, which often presents with nonspecific EKG changes but a negative troponin. Treatment of STEMI, NSTEMI, and unstable angina are acute conditions, so we'll cover that in the emergency med video. Some of the other differentials for chest pain include Prince-Metal variant angina, pericarditis, aortic dissection, pulmonary embolism, pulmonary hypertension, carditis, and costochondritis. So let's briefly go through each of these now, but they'll all be covered in more depth in other videos. So Prince-Metal variant angina, also called vasospastic angina, is when coronary artery vasospasms cause transient ST elevations and non-exertional chest pain, often at rest. Risk factors include smoking and cocaine abuse. And diagnosis is made by doing coronary angiography in the cath lab and injecting a provocative agent like ergonovine, which induces vasospasms. The treatment of choice for Prince-Metal angina is calcium channel blockers. Next is pericarditis, which causes chest pain that is relieved by leaning forward and is worse when laying supine or during inspiration. Pericarditis is an inflammation of the pericardial sac. On exam, a pericardial friction rub can be heard when the patient is upright and leaning forward, and patients often have a fever as well. EKG will show diffuse ST elevation in the precordial leads, that's V1 through 6, with associated PR depressions. An echo will often be done too to rule out any complications, like pericardial effusions, which commonly occur with pericarditis. Treatment is NSAIDs or aspirin as an anti-inflammatory, and colchicine is second line. Aortic dissections cause a severe tearing or ripping type chest pain that radiates to the back between the scapula. An aortic dissection is a tear in the intima or the innermost layer of the aorta. Blood under high pressure flows into this tear, creating a false lumen. High blood pressure is the most important predisposing factor. MRI angiography is the gold standard for diagnosis. If the tear is at the ascending aorta, called a type A, the dissection is a surgical emergency. And if the tear is at the descending aorta, called a type B dissection, then it's initially managed medically with beta blockers. Pulmonary embolisms, or PEs, most commonly cause shortness of breath, but also cause a pleuritic chest pain. PEs occur when a thrombus enters the pulmonary artery or its branches, typically a result of a deep vein thrombosis or DVT in a lower extremity. The best initial test for PE diagnosis is a helical CT scan, but depending on the circumstances, other testing might include a venous Doppler ultrasound, VQ scan, pulmonary angiography, chest X-ray, or D-dimer. Treatment for pulmonary embolisms is typically anticoagulation. Pulmonary hypertension causes dyspnea with exertion, chest pain, edema, and syncope. Pulmonary hypertension occurs when the blood pressure in the lungs is increased, which can be due to left heart disease, chronic lung disease, mitral stenosis, etc. A right heart catheterization is the gold standard for diagnosis since it can directly measure the pressure there. Treatment depends on the underlying cause. Carditis also causes chest pain or discomfort and is most commonly a result of rheumatic fever. So other symptoms can include joint pains, subcutaneous nodules, erythema marginatum, and Sydenham's chorea. Remember the Jones criteria here. So rheumatic fever is an immune reaction that occurs 2 to 4 weeks after a group A strep infection, normally strep throat. Diagnosis is based on the Jones criteria, and treatment involves aspirin and corticosteroids for the inflammation in carditis and penicillin G in all patients. The last differential we'll include here is costochondritis, which causes pleuritic chest pain that gets worse with inspiration, palpation, or movement of the arms or torso. Costochondritis is inflammation of the costochondral, costosternal, or sternoclavicular joints, and it's pretty common after either musculoskeletal trauma or strain, or a viral illness where you're coughing a lot. Costochondritis is treated with rest so the area can heal, and NSAIDs can help with discomfort. Just a note, this is not a complete list of differentials for chest pain by any means. These are just a few top differentials to know for the exam. Other possibilities include muscle strain, GERD or reflux, pneumonia, collapsed lung, esophageal spasm, rib fractures, shingles, anxiety, acute chest and sickle cell, and the list goes on and on. The next topic is arrhythmias. This is a good one. This is my favorite. So, basics first. In a normal EKG, the first wave is the P wave, which represents the depolarization of the atria. The QRS complex is next, and this represents the depolarization of the ventricles. Last is the T wave, which represents the repolarization of the ventricles. When you read an EKG, it's important to go through the rhythm strip systematically. There are a bunch of different ways to do this, so here's just one example. Step 1, determine if the rhythm is regular or irregular by checking the R to R intervals, making sure that the number of small boxes from one R wave to the next is consistent. Step 2, determine the rate. If you have a 6-second rhythm strip, you can multiply the number of R waves by 10 to get the heart rate. Step 3, look at the P waves and the PR interval. Are there P waves, and if so, is each one followed by a QRS? Do all the P waves look the same? Is the PR interval normal within 3 to 5 small boxes? If each P wave looks the same and is followed by a narrow QRS complex, then the patient is in sinus rhythm. Step 4, look at the QRS complex. Is it narrow or wide? If it's wide, is it due to a bundle branch block, ventricular hypertrophy, or a ventricular rhythm? A wide QRS is greater than 3 small boxes. Step 5. Look at the T wave and the QT interval. Is the T wave inverted, peaked, or flattened? Is the QT interval prolonged? And if you have an entire 12 lead instead of just an EKG rhythm strip, this systematic approach would include evaluation of the ST segment, axis deviation, etc. But we'll stick to just rhythm strips here. A sinus rhythm means that the impulses originate from the sinoatrial node, or SA node, which is the default natural cardiac pacemaker located in the upper right atrium. If a rhythm originates in the atria but not the SA node, it's called an atrial rhythm. These rhythms have a P wave because the atria are still being depolarized, but its shape might be different from a sinus rhythm impulse because it's following a different pathway to the AV node. So the AV node, or atrioventricular node, is a separate cardiac pacemaker located in the inferior posterior right atrium. This node slows down electrical impulses just slightly so that the atria can contract before the ventricles. The bundle of His is another separate cardiac pacemaker that connects the AV node to the left and right bundle branches. Rhythms that originate from the AV node or the His bundle are called junctional rhythms. After the bundle of His are the Purkinje fibers, which carry impulses to the ventricles. When impulses originate here, they're called ventricular rhythms and are often unstable with wide, bizarre-looking QRS complexes. And ventricular rhythms have no P waves since the atria aren't depolarizing. So just to summarize, the normal electrical pathway of an impulse through the heart originates in the SA node and proceeds to the AV node, where impulses are slowed down slightly to allow for the atria to contract before the ventricles. Then the impulse continues down the bundle of His and Purkinje fibers to contract the ventricles. Now let's move on to rhythms, starting with sinus rhythms. In normal sinus rhythm, every P wave is followed by a QRS complex, and it has a rate of 60 to 100. If it's faster than this, the rhythm is called sinus tachycardia, and slower than this is called sinus bradycardia. You might see something called sinus arrhythmia, which is actually totally normal and just describes a sinus rhythm where the heart rate increases slightly during inspiration and decreases slightly during expiration. Again, even though it says arrhythmia, it's completely normal. Then there is sick sinus syndrome, sometimes called sinus node dysfunction, where the rhythm is a combination of sinus arrest with atrial tachycardia and bradycardia. These patients might need an implantable pacemaker. And just a quick differentiation here, a sinus pause lasts for less than 3 seconds, while a sinus arrest lasts for more than 3 seconds. Or more than 15 large boxes, since you might have noticed I like talking about boxes a lot more than fractions of seconds. All right, on to AFib and aflutter. These are atrial rhythms because they originate in the atria, but not the SA node. Atrial fibrillation is an irregularly irregular rhythm with no discernible P waves, just fibrillatory waves. There is usually a narrow QRS with a rate of 80 to 140 beats per minute. AFib is the most common chronic arrhythmia, and most patients are asymptomatic, but it can also cause syncope, dyspnea, and palpitations. And the quivering of the atria can predispose these patients to form clots there. Treatment of AFib prioritizes rate control over rhythm control. Atrial flutter, unlike AFib, is usually regular and is characterized by these sawtooth waves instead of P waves. Management of A-flutter is similar to AFib. Next is SVT, which is also classified as an atrial rhythm. Paroxysmal supraventricular tachycardia, or SVT, is a regular, narrow complex tachycardia, meaning more than 100 beats per minute, with no discernible P waves. Since we can't see the P waves due to the rate, we can't know if it's a sinus rhythm, meaning we can't know if the impulses originate in the SA node. But we do know that they originate above the ventricles, hence supraventricular tachycardia. SVT is more of an umbrella term when a more specific rhythm can't be identified but is fast and originating above the ventricles. If the patient is stable, SVT can be treated with vagal maneuvers, adenosine, beta blockers, or calcium channel blockers. If the patient is unstable, synchronized cardioversion is appropriate, and definitive treatment is ablation. Some other atrial rhythms that we aren't going to go through here but might be good to know are multifocal atrial tachycardia, wandering atrial pacemaker, and Wolff-Parkinson-White syndrome. Next, let's go through the atrioventricular conduction blocks, or AV blocks. This is an interruption of the normal impulse from the SA node to the AV node. In a first-degree AV block, the rhythm looks very similar to normal sinus rhythm, P waves followed by QRS, but the PR interval is prolonged, longer than 5 small boxes or 0.2 seconds. The impulses are still conducted from the atria to the ventricles, but they're just delayed. And there are some goofy rhymes for each of these AV blocks. So here's the first one. If R is far from P, then you have a first degree, the prolonged PR interval. In a second degree AV block, not all of the atrial impulses make it to the ventricles. Some of the P waves do not have a QRS complex after them. There are 2 types of second degree AV block: Mobitz type 1 or Winky Bach, and Mobitz type 2. In type 1 or Winky Bach, the PR interval gets progressively longer until it eventually just drops the QRS complex entirely. There will be a P wave with no QRS after it because the atrial impulse was not conducted to the ventricles. This rhythm is often asymptomatic, but treatment might include atropine if the patient is actually symptomatic. And here's the goofy rhyme for this one. If PR gets longer, drop, then it's a case of Winky Bach. In Mobitz type 2, the PR interval is consistent, but there is an intermittently dropped QRS. So every few beats, there might be a P wave with no QRS after it. Definitive treatment for this AV block is an implantable pacemaker. And here's the rhyme. If some R's just don't get through, prepare to pace that Mobitz 2. A second degree type 2 heart block commonly progresses to a third degree block. In a third degree block, there is a complete AV dissociation, so the P waves do not correspond to the QRS complexes at all. There's equal distance from P wave to P wave, and there's equal distance from QRS to QRS, but none of the P waves are followed by a QRS. The atria and ventricles are each just marching to the beat of their own drummer. This leads to decreased cardiac output, and so the definitive treatment is an implantable pacemaker. And here's the last rhyme. If R's and P's just can't agree, prepare to pace that third degree. So far, we've mostly gone over some of the dysrhythmias that originate above the ventricles, but before we move on to ventricular rhythms, let's talk about premature beats. These are complexes or beats that come early in the rhythm and are followed by a compensatory pause before the next normal beat. These premature beats can be atrial, junctional, or ventricular, depending on where the impulse originates. Premature atrial complexes, or PACs, originate from ectopic foci in the atria and look like an abnormal P wave followed by a narrow QRS. Premature junctional complexes, or PJCs, originate from ectopic foci near the AV junction and result in either no visible P wave or a retrograde P wave that can appear before, during, or after a narrow QRS. PJCs normally produce a narrow QRS, but it's possible for them to produce a wider one, just depending on how they conduct the impulse. Premature ventricular complexes, or PVCs, originate from the Purkinje fibers in the ventricles, and they appear as a wide QRS complex, meaning wider than 3 small boxes. If PVCs continuously alternate every other beat with a regular sinus beat, this is called bigeminy. And if every third beat is a PVC, meaning 2 regular beats, a PVC, 2 regular beats, a PVC, continuously, then this is called trigeminy. Then 2 consecutive PVCs in a row, just back to back without normal beats in between, 2 PVCs in a row are called a couplet, and 3 PVCs in a row are called a triplet. More than 3 back-to-back PVCs becomes runs of VTAC, which we'll go over now. Ventricular tachycardia, or VTAC, is defined as 3 or more consecutive PVCs with a rate above 100. If you see this rhythm, check your patient's pulse. VTAC can occur with or without a pulse. If the patient is stable with sustained VTAC, sustained meaning more than 30 seconds, treatment is an antiarrhythmic like amiodarone. If they are unstable but with a pulse, treatment is immediate synchronized cardioversion. Unstable gets the cable if you need a memory trick. And if the patient has no pulse, defibrillate and start CPR. You're going down the ACLS algorithm there. One type of VTAC is called torsades de pointes. This is a polymorphic ventricular tachycardia, so there are multiple QRS morphologies. On the EKG, it looks like the QRS complexes are kind of twisting around the isometric line. Treatment for torsades is magnesium sulfate. Next is VFib. Ventricular fibrillation is a lethal rhythm in which the ventricles are attempting to contract at rates up to 500 beats per minute. Obviously, the heart can't contract in a synchronized way that fast, so it just ends up kind of quivering, leading to an immediate loss of cardiac output. On an EKG, this just looks like a wavy or shaky line with no discernible P waves, QRS complexes, or T waves. The patient will not have a pulse, and treatment is defibrillation and CPR, going down the ACLS algorithm. There are 2 other lethal rhythms to go over. Pulseless electrical activity, or PAEA, is when an organized rhythm is seen on an EKG, but the patient has no palpable pulse. The electrical activity in the heart, which is being read by the EKG, is not able to get the heart muscle to actually contract, so blood isn't being pumped. This is not a shockable rhythm, but treatment is CPR and epi and continue down the ACLS algorithm. Finally, asystole, or a flat line, is a state of no cardiac electrical activity at all. That means no contraction and no cardiac output. Treatment is the same as PAEA, CPR and epi, and the ACLS algorithm. Now we're on to heart failure. Heart failure is the failure of the heart to pump sufficient blood to meet the demands of the body. The most common cause is coronary artery disease, but other common causes include hypertension, myocardial infarction, diabetes, and ventricular remodeling. Symptoms of heart failure include dyspnea, chronic cough, fatigue, orthopnea, paroxysmal nocturnal dyspnea, peripheral edema, rales or crackles, additional S3 or S4 heart sounds, increased jugular venous pressure, ascites, and cyanosis. The New York Heart Association classifies heart failure into 4 functional classes based on symptoms. Class 1 heart failure patients have no symptoms and no limitations during ordinary physical activity. Class 2 patients have slight limitation during ordinary physical activity, but they're comfortable at rest. Class 3 patients have marked limitation during activity, even with minimal exertion, but they are also comfortable at rest. And Class 4 patients have symptoms even at rest with severe limitations and an inability to carry out physical activity. So there are different types of heart failure. When we say congestive heart failure, or CHF, we're often talking about acute decompensated heart failure with symptoms of pulmonary congestion. But to be thorough, let's detour briefly into the other kinds of heart failure. It can be right or left-sided. It can be systolic or diastolic failure. It can have high output or low output, and heart failure can be acute, chronic, or acute on chronic. So let's go over these variations. Left-sided heart failure is exactly what it sounds like, left ventricular dysfunction. It's most commonly caused by coronary artery disease and hypertension, and the predominant symptom of left-sided heart failure is shortness of breath. This makes sense if you think about the circulatory anatomy, though. If the left ventricle is struggling to pump blood out to the body, then there will be a backup of blood that starts at the left ventricle. This buildup continues backward into the pulmonary veins and then the lungs, which leads to dyspnea and rales or rhonchi. Other symptoms of left-sided heart failure include eventual orthopnea and paroxysmal nocturnal dyspnea, pulmonary congestion, chronic non-productive cough, especially with pink frothy sputum, wheezing, and transudative pleural effusions. Left-sided heart failure is much more common than right-sided. In fact, the most common cause of right-sided heart failure is left-sided heart failure. Other common causes are pulmonary disease like COPD and pulmonary hypertension. Right-sided heart failure is right ventricular dysfunction. The predominant symptom is peripheral edema, and this makes sense too. If the right ventricle is failing, then blood will start to build up at the right ventricle and continue backwards into the vena cava and the body's venous system, leading to fluid accumulation there. Other symptoms of right-sided heart failure include pitting edema, jugular venous distension, hepatosplenomegaly, and ascites. And in patients with biventricular heart failure, you'll see a mix of right and left-sided heart symptoms. So now, systolic versus diastolic. Systolic heart failure occurs when the heart has become weak and cannot contract as effectively, resulting in a reduced ejection fraction. The ventricle walls are thin with a dilated left ventricular chamber. Auscultation might reveal an S3 gallop. Systolic heart failure is the more common form and results from myocardial infarction or coronary artery disease that damages the heart muscle, dilated cardiomyopathy, or myocarditis. Diastolic heart failure is less common, and it occurs when the heart cannot relax enough to fill up properly with blood. This results in a preserved or even increased ejection fraction, but still not enough blood getting pumped out to the body. The ventricular walls are going to be thick with a small left ventricular chamber. Auscultation might reveal an S4 gallop due to the stiff ventricle. Diastolic heart failure can be caused by left ventricular hypertrophy, hypertension, hypertrophic or restrictive cardiomyopathies, valvular heart disease, or constrictive pericarditis. And for terminology's sake, systolic heart failure is also called heart failure with reduced ejection fraction, or HFrEF. And diastolic heart failure is also called heart failure with preserved ejection fraction. Now, high versus low output. High output heart failure is caused by increased metabolic demands of the body, so it can be brought on by conditions like thyrotoxicosis, wet beriberi or thiamine deficiency, severe anemia, AV shunting, Paget's disease of the bone, etc. High output heart failure will start with tachycardia, but once the heart is tired out, it's going to resemble systolic heart failure with a weak and dilated heart muscle. Low output heart failure is simply an inherent problem of myocardial contraction, ischemia, and chronic hypertension. And finally, acute versus chronic. Acute heart failure is typically systolic, resulting from hypertensive crisis, myocardial infarction, papillary muscle rupture, etc. Chronic heart failure is commonly seen in patients with dilated cardiomyopathy or valvular disease, which we'll go over in the next section. Now back to focusing on congestive heart failure. The most useful test to diagnose CHF is an echocardiogram. This will estimate ejection fraction, which is the most important determinant of prognosis. A normal ejection fraction is 55 to 60%, and anything less than 35% should get an implantable cardioverter defibrillator to reduce mortality risk. BNP, or B-type natriuretic peptide, is a lab value that can indicate severity and prognosis of heart failure. BNP is released by the ventricles during times of volume overload in an attempt to fix that excessive fluid. It causes a decrease in RAS activation, which lowers total body fluid volume and increases sodium excretion. When the ventricles are overloaded due to congestive heart failure, they release BNP for the same reason. And lastly, another diagnostic test is a chest x-ray. In CHF, chest x-ray might show curly B lines, cardiomegaly, cephalization of vessels, and pleural effusions or pulmonary edema. Management of CHF always starts with lifestyle modifications. Heart failure patients need to restrict their sodium intake to less than 2 grams per day and their fluid intake to less than 2 liters per day. Long-term management typically includes an ACE inhibitor, beta blocker, vasodilator, and diuretic. Acute treatment can be remembered by the acronym LMNOP, which stands for Lasix, morphine, nitrates, oxygen, and position. Diuretics like Lasix or furosemide remove excess fluid. Morphine is not commonly used now, but can reduce preload and therefore heart strain. Nitrates or other vasodilators reduce preload and afterload. Oxygen, like BiPAP or CPAP, can increase oxygenation and decrease work of breathing, and an upright position can decrease venous return. If the patient presents with signs of hypotension or shock, inotropic support might be necessary. And that wraps up the heart failure topic. Let's start the valvular disease section with a quick review. So blood enters the right atrium, passes through the tricuspid valve into the left atrium, passes through the pulmonary valve into the pulmonary artery, and then the lung. Blood gets oxygenated and then travels the pulmonary veins into the left atrium, passes through the mitral valve into the left ventricle, passes through the aortic valve into the aorta, and then out into the body. As the heart is pumping this blood, it's doing so in 2 phases: systole, when the heart contracts, and diastole, when the heart relaxes. When we talk about valvular disease, there are 2 main conditions: stenosis and regurgitation. And there are 2 main valves affected by these conditions: the mitral and aortic valves. So we'll start there. Aortic stenosis, which is the most common valvular disease, is an obstruction of left ventricular outflow. It can lead to left ventricular hypertrophy and failure. In fact, once a patient becomes symptomatic, the valve needs to be replaced or their lifespan will be significantly shortened. The most common symptom is exertional dyspnea, but other symptoms include angina, syncope or dizziness, and congestive heart failure. On exam, aortic stenosis presents with a systolic ejection crescendo-decrescendo murmur at the right upper sternal border that radiates to the carotid. It might also present with a narrow pulse pressure or pulsus parvus et tardus, which is a delayed weak carotid pulse. Diagnosis is made by echocardiogram, and the only effective treatment is valve replacement once the patient is symptomatic. Aortic regurgitation occurs when there is incomplete aortic valve closure during diastole, leading to regurgitation of blood from the aorta to the left ventricle. This causes left ventricular volume overload and eventually CHF. On exam, aortic regurg presents with a diastolic decrescendo blowing murmur, best heard at the left upper sternal border. It might also present with bounding pulses, wide pulse pressure, head bobbing, nail bed pulsations, water hammer pulse, and pulsus bisferiens, which is a double pulse carotid upstroke. Diagnosis is made by echocardiogram again, and treatment might include vasodilators for afterload reduction, but a valve surgery is definitive management. Mitral stenosis is an obstruction of left atrial outflow. This causes blood to back up in the left atrium, which leads to pulmonary congestion, pulmonary hypertension, and CHF. Mitral stenosis is almost always caused by rheumatic heart disease. On exam, it presents with an opening snap and a diastolic rumble best heard at the apex, as well as a prominent S1 heart sound. It can also present with pulmonary symptoms, hemoptysis, AFib, mitral phases, and right-sided heart failure. Diagnosis is made by echocardiogram, and definitive treatment is surgery, often a valve repair. Mitral regurgitation occurs when there is incomplete mitral valve closure, leading to regurgitation of blood from the left ventricle into the atria, which then returns to the ventricle during diastole. This causes left ventricular volume overflow, left atrial dilation, increased pulmonary pressures, and decreased cardiac output. On exam, mitral regurg presents with a blowing hollow systolic murmur, best heard at the apex, that radiates to the axilla, as well as a widely split S2 heart sound. It can also present with pulmonary symptoms, AFib, and CHF. Diagnosis is also made by echocardiogram. Treatment is surgery, and valve repair is preferred over replacement. In non-operative patients, vasodilators can be used to decrease afterload. And lastly, mitral valve prolapse, which is the most common cause of mitral regurg, is a bulging of part of the mitral valve that results in a floppy or redundant valve. These are most commonly asymptomatic, but they can cause palpitations, syncope, or panic attacks. On exam, mitral valve prolapse presents with a mid-late systolic ejection click. Diagnosis is made by echo, and typically treatment is not necessary. Endocarditis is an inflammation of the endothelium and/or heart valves secondary to a bacterial infection. Bacteria can be introduced into the bloodstream through dental or medical procedures in the mouth, GI, or urinary tract, or through intravenous drug use. Symptoms of infective endocarditis can be remembered with the acronym from Jane. I'm just going to list these out starting with F. Fever, Roth spots, Osler nodes, murmur, heart murmur, Janeway lesions, anemia, nail bed hemorrhages or splinter hemorrhages, and emboli. From Jane. Infective endocarditis can be acute or subacute. Acute bacterial endocarditis is an infection of normal valves, typically the native mitral valve, with a virulent organism, most commonly Staph aureus. Subacute bacterial endocarditis is an indolent infection of abnormal heart valves with a less virulent organism, commonly Strep viridans. In IV drug users, endocarditis most commonly affects the tricuspid valve with Staph aureus, but the organism can also be Pseudomonas or Candida. In patients with endocarditis of prosthetic heart valves, the most common organism is Staph epidermidis. Diagnosis of endocarditis can be made by Duke's criteria, and usually an echocardiogram. Specifically, a transesophageal echo is the gold standard. So here's Duke's criteria for diagnosis of infective endocarditis. There are major and minor criteria. The major criteria are 2 positive blood cultures, an echocardiogram positive for vegetation, abscess, or valve perforation, and new valvular regurgitation murmur. Those are the major criteria. The minor criteria are a predisposing condition, fever, vascular or embolic phenomenon, immunologic phenomenon, a positive blood culture that didn't meet major criteria, and a positive echo that didn't meet major criteria. So using Duke's criteria, definitive diagnosis is made with 2 major criteria, or 1 major and 3 minor, or just 5 minor criteria. Treatment of endocarditis is IV antibiotics based on the organism for about 4 to 6 weeks. Often vancomycin and penicillin are used for gram-positive coverage, and vanc if MRSA is suspected, and gentamicin is good for gram-negative coverage. Rifampin might be added for prosthetic heart valves, and in cases of fungal endocarditis, amphotericin B is used along with surgical intervention. Prophylactic antibiotics are also given in certain patients prior to dental procedures or invasive respiratory procedures. Patients with prosthetic heart valves, congenital heart disease, and those with previous cases of infective endocarditis receive amoxicillin 1 hour prior to a procedure. The last topic is peripheral vascular disease, which can be broken down into arterial and venous disease. Peripheral arterial disease is atherosclerosis of the arteries of the lower extremities. The most common symptom is intermittent claudication that is reproducible and brought on by exercise or walking, and relieved with rest. The location of the claudication or pain is determined by the location of the atherosclerosis. When the aortic bifurcation or common iliac is involved, pain presents in the buttock, hip, or groin. When this pain is accompanied by impotence in men and decreased femoral pulses, it's actually called Larich's syndrome or aortoiliac occlusive disease. When the femoral artery is involved, pain is in the thigh and upper calf. When the popliteal artery is involved, pain is in the lower calf, ankle, and foot. And when the tibial and peritoneal arteries are involved, pain is in the foot. Other symptoms of peripheral artery disease include decreased or absent pulses, bruits, increased capillary refill time, atrophic skin changes, muscle atrophy, hair loss, thickened toenails, pale, cool skin, dependent rubor, and ulcers at points of trauma, commonly the toes and lateral malleolus. Signs of advanced disease include resting leg pain with limb-threatening ischemia, acute arterial embolism, and gangrene. Angiography is the gold standard for diagnosis, but an ankle brachial index is much more commonly used. An ankle brachial index, or ABI, is done using Doppler measurements to compare the blood pressure in the lower extremity, ankle, and upper extremity, brachial. It is highly sensitive and specific. If ABI is less than 0.9, then the diagnosis is peripheral artery disease. And if it's less than 0.5, it's severe. Treatment involves graded exercise and platelet inhibitors. First line is cilostazol, and aspirin and clopidogrel are used as well. In severe disease, revascularization might be necessary. This can be done by percutaneous transluminal angioplasty, bypass grafts, and endarterectomy. All right, on to venous disease. Chronic venous insufficiency is incompetency of either the deep or superficial veins of the lower extremities. Quick anatomy review here. The superficial venous system consists of the greater and lesser saphenous veins, and the deep venous system consists of the veins that accompany major arteries, and these carry about 90% of venous return from the legs. Then there are the perforating veins that communicate between the deep and superficial ones. All right, back to venous insufficiency. It typically presents with leg pain that is worse with prolonged standing or sitting or any activity where the foot is down low, and it improves with leg elevation and walking. It also presents with leg edema or even pitting edema because the veins are not efficiently returning blood to the heart, so fluid accumulates in the legs. Other symptoms include varicosities, erythema, stasis dermatitis, brownish hyperpigmentation, and venous stasis ulcers on the medial portion of the leg, especially the medial malleolus. Diagnosis is primarily clinical, but a venous Doppler can rule out DVT. Treatment includes leg elevation, compression stockings, graded exercise, ulcer management, and in severe cases, a venous valve transplant. And that's it. That wraps up the cardiovascular portion of the Family Medicine EOR exam study guide. If you're listening to these videos as they're rolling out, the pulmonology section will be uploaded very soon. But I also might start uploading some of the other EOR topics concurrently since there's a lot of content recorded but not yet uploaded. So stay tuned, subscribe to the channel, and thank you so much for listening. Happy studying, and I'll see you in the next video.